We want to speak about humoral immunity and activation of the lymphocytes. We have two major pathways of B cell activation. In one pathway, the B cell need T cells for activation, and in other pathway, it's a T cell independent activation of B cells. In T cell independent B cell activation, many polysaccharide and liquid oxygen they can simultaneously engage and cross-link antibody molecules, and the initiation of process of B cell activation will happen without any dependence to T cells, without any antigen presenting, for example. But in T cell dependent B cell activation, B cell first act as antigen presenting cell. They present the antigen to class by present antigen by class 2 MHC to T helper cells, and T helper cells have expressed CD40 ligand and secret cytokine, for example interleukin 2, and these cytokines work together to activate the B cells. So B cell activation may be via T cells or maybe independent T cells. When B cells differentiate to plasma cells, each plasma cell secretes antibody with the same specificity as the cell surface antibody for B cell receptor that first recognizes the antigen. Polysaccharide and lipid stimulate IgM antibody. Protein antigen induce production of antibody of different classes. IgG, IgA, IgA. So first you have an IgM antibody as B cell receptor, or probably IgD. Okay, but your body should produce different type of antibody. For example, IgA, IgG, IgE against some protein antigen. Do you know what's the process which is turning IgM? First, you only have IgM, but different classes of antibody are producing in our body. Do you know what's the process of this changing IgM to other type of antibody?
Class switching.
Yes, exactly. Class switching. Production of functionally different antibody, all with the same specificity, relies on heavy chain class isotype switching, which increase the range of function that antibodies serve. So first, in the first step, you only have IgM as B cell receptor or IgD. But in the other step, you have production of IgA, IgE, IgG from IgM. This process of changing heavy chain class isotype switching. This is isotype switching. The T helper cells stimulate provisioning of IgM positive, IgD positive B cell lymphocyte on the surface of lymphocytes, and antibody of different heavy chain class initiated by CD40 ligand mediated signals. This is a B cell, for example. This is the function of B cells. B cells produce here. We have some activation of helper cells. The helper cells. The helper cells produce interferon gamma for activation of macrophages. Produce interleukin 4 for activation of, for example, eosinophils. And you have here some isotype switching. These are different types of antibody. IgM is the first antibody which is present in the B cell receptor. But other type of antibody, for example, IgG and IgE and IgA producing from IgM. T helper cells also stimulate the production of antibody with higher affinity for the antigen. The first affinity is between B cell receptor and antigen, but other antibody which are producing after the first stimulation should have more affinity for antigen. And we call this process affinity maturation. The affinity of subsequent antibody which are produced to antigen are more than the first B cell receptor antigen. This process called affinity maturation, which improves the quality of humoral immune response. So what was isotype switching? Tell me what was isotype switching and what was affinity maturation?
Isotype switching is the class switching. It's when we have one type of antibodies referred to another.
Yeah.
Affinity switching, although I didn't.
Affinity maturation.
It just helps the
Maturation, I
humoral
did.
system
Is it-
become better.
What is affinity maturation?
It just helps the humoral system become more affinited to antigen.
You have a first affinity between B cell receptor or IgM to an antigen, okay? But after the plasma cells are producing subsequent antibody, the affinity of subsequent antibody production to antigen should be more than the first affinity of the B cell receptor and antigen. It means it's called by affinity maturation. In the subsequent antibody production, we have more affinity to antigen from the more than the first exposure of antigen to B cell receptor. It means affinity maturation. Some activated B cells migrate into lymphoid follicles and form germinal center, which are the major site of isotype switching and affinity maturation. So the main part in the body that isotype switching and affinity maturation happen are in the germinal center of the lymph nodes. The helper T cells that stimulate this process in B lymphocyte also migrate to germinal centers and called follicular T helper cells. T helper cells usually present in parafollicular cortex, but we have few T helper cells in the germinal center for the process of affinity maturation and isotype switching. We call them follicular helper T cells, TFX cells. And this is a picture from your book. Here you have a main B cells, the first B cell receptor and the B cells are IgM or IgD. Yeah? And you have T helper cell stimulation. You have proliferation of these innate B cells. Maybe they produce interleukin 2 here. And we have proliferation of B cells. And we have differentiation of B cells. And we have three functions. Antibody secretion by plasma cells. We have class switching. For example, the first antibody is IgM or IgD, but here we have IgG expressing B cells. So this is class switching. We have affinity maturation. We have high affinity IgE immunoglobulin expressing B cells. And we have production of some memory cells here. And these are the function of antibody. Antibody may attach to surface of microbes and neutralize them, or they may opsonize them for phagocytes. You know what is the process of opsonization? Opsonization means making delicious. The antibody attach to surface of microbe and make the microbe delicious for the phagocytes to phagocyte them. Okay? And we have antibody-dependent cytotoxicity. For example, some of the antibody attached to surface of the microbes, and some NK cells may have action here. And we have complement activation. Some types of antibody can activate the complement system. Neutralizing means prevent microbe from infecting cell. Opsonization mainly happen by IgG antibody. This IgG antibody coat or opsonize microbes to target them for phagocytes. And IgG and IgM can activate complement system, but other type of antibody, for example IgE or IgD, IgE, they cannot activate the complement system. IgA secret in mucosal tissue is very important antibody in the mucosal tissue, and neutralize microbe in the respiratory or gastrointestinal mucosa of the respiratory system or gastrointestinal system. It's very important. IgG actively transport across the placenta and protect the newborn. We call this passive immunity. So what is passive immunity? the IgG when transformed by placenta to a baby. A baby in the first 6 months of the life, the baby have antibody from the mother, and the baby, the level of antibody production in the baby is very low. All of the antibody in the baby body is from the transporting of IgG from placenta to the baby, from mother to via placenta to baby. IgM cannot transport via placenta, only IgG can transport via placenta. IgE coats the parasites and function with mast cells and eosinophils to kill them. So IgE have a function in eliminating helminths and parasites, and also in anaphylactic reaction. IgE attached to surface of mast cells for anaphylactic reaction. Circulating IgG antibody half-life is about 3 weeks, which is much longer than the half-life of most blood protein. And when a process of immune system against defending against microbe is eliminated, the majority of effector lymphocytes die by apoptosis. Okay, they die by apoptosis when the pathogen is eliminated, and we have some memory long-lived memory cells which may survive for years after the infection for the second exposure, second probable exposure. Okay, with the concept of lymphocyte activation, lymphocyte activation, and the defense adaptive immunity is finishing here. Now we want to speak about hypersensitivity reaction. Hypersensitivity reaction. When an immune system is activated more than it is needed, we have hypersensitivity reaction, or may have autoimmune disorder. We speak about autoimmune disorder in your other sessions, I think Sunday and Monday. Autoimmune disorder they speak about. But here we want to speak about hypersensitivity reaction. Injurious immune reaction are categorized under 3 major types. Autoimmunity, reaction against microbes, or reaction against environmental antigen. What is autoimmunity? Autoimmunity is reaction of immune system against self-antigen. And we have a phenomenon self-tolerance. The immune system does not react against one's own antigen. It means the name of this process is self-tolerance. Hypersensitivity reaction means excessive undesirable reaction produced by normal immune system. All of hypersensitivity reaction requires a perisensitized state of cause. You will need a first exposure. And in the first exposure, the person may do not have any symptom. The symptom may begin from the second or subsequent exposure. Hypersensitivity reaction can be divided into 4 types: type 1, type 2, type 3, and type 4. And they are very susceptible for question in your exam. I think 1 or 2 questions may be from all of these hypersensitivity reactions. Type 1 hypersensitivity reaction, also known as immediate or anaphylactic hypersensitivity reaction, take action within 50 minutes to 30 minutes from time of exposure. It's very immediate, this type of reaction. And the reaction involves skin, for example, urticaria or eczema, eyes in the form of conjunctivitis, nasopharynx, allergic rhinitis, and bronchopulmonary tissue, for example, asthma, and gastrointestinal tract. And it may have systemic effect. When the type 1 hypersensitivity reaction has systemic effect, we call this anaphylactic shock. Why this should happen? because the massive drop in blood pressure. The allergen may be pollen or dust mite and mediated by IgE, and primary cellular component are mast cells or basophils or basophils. The reaction is amplified by other cells such as eosinophils. So this is a schematic picture of the anaphylactic reaction. You have a first exposure, for example, to pollen or some environmental antigen, and in the first exposure, IgE immunoglobulin are produced, but the next person do not have any symptom. These IgE antibodies are attaching to the surface of mast cells or basophils. Basophils have many granules, for example, histamine, the major granule in the mast cells. And in the second exposure, the allergen attached to IgE antibody on the surface of mast cells. And mast cells degranulated, the granule of the mast cells are releasing from the mast cells, for example, histamine. And histamine causes a severe drop in the blood pressure, extravasation of blood from the blood vessels, and anaphylactic shock will be happening. It's not clear why some individuals are more prone for type 1 hypersensitivity. And maybe some of these patients have a more effective T helper T cells and secretion of interleukin 4, interleukin 5, and interleukin 13 are more in these patients, which turn in favor of IgE class switching. IgE is more in the body of these patients. IgE has very high affinity for its receptor on the mast cell surface, and its mediator of immediate hypersensitivity reaction on histamine. Histamine causes dilation and increased permeability of blood vessels, swelling, redness, increased mucus secretion, smooth muscle contraction, and they also mast cells have prostaglandins, which can cause contraction of the smooth muscle of respiratory system, in dyspnea and asthma caused by this contraction of the smooth muscle, and increased mucus secretion, and leukotrienes, which lead to bronchial spasm. And this is a picture from here is dendritic cell, present antigen to T cell. This is the first exposure. This is about the first. Oh, you can see my, yes, you can see my mouse. This is first exposure. First exposure leads to IgE secreting plasma cells, IgE attached to surface of mast cells, and the activation of mast cell leads to release of mediators, and cytokine production. And this is also a picture from your book. This is hours after allergen exposure. First allergen exposure is here. You have immediate reaction, which is within 1 hour from the exposure to allergen, and you have a late phase reaction. If you have a tissue section from the tissue which have undergone type 1 hypersensitivity, you can see many mast cells. Mast cell in the tissue is here, and you can see granules of mast cells. They are very basophil granules. And these are vascular. This is the vessel which undergone congestion, edema here, and here you can see many eosinophils here. The eosinophils here, and also you have some other neutrophils and lymphocyte T cells. It's a late phase. The picture is from late phase, but this picture is from immediate phase. In the immediate phase, you have mast cells, but in the late phase, you have eosinophils, neutrophils, T cells. So we have anaphylaxis, which is systemic response of type 1 hypersensitivity reaction. With the hypersensitivity reaction may also have a localized response in form of atopia. Okay, good. And this is a table from your book. Disorder caused by immediate hypersensitivity, anaphylaxis, fall in blood pressure, bronchial asthma, allergic rhinitis, and food allergy. It's very important. You should know the examples of each hypersensitivity reaction. For example, type 1.
Allergies and allergy-like
yes,
symptoms.
anaphylaxis,
Asthma.
bronchial asthma, allergic rhinitis,
Bronchial.
and food allergy. These are examples of type 1. Type 2 hypersensitivity reaction. Type 2 is antibody-mediated disease. Antibody-mediated or type 2 hypersensitivity disorder caused by antibody directed against target antigen on the surface of cells or tissue component. You have some
Matrix.
antigen in our body tissue and you have some antibody against them. Antibody cause disease by targeting cell by phagocytosis, activating the complement system, or interfering with normal cellular function. For example, this is a cell in our body, and these are some antigens, some antigens in the surface of the cells. You have antibody production, and antibody directly attached to the surface of antigen in the tissue. You have complement activation, and you have activation of anchor cells and phagocytosis, and the disease will be happening. These are, I think it may be difficult for have in mind, but these are the examples of type 2 hypersensitivity reaction. For example, autoimmune hemolytic anemia.
Oxidization.
Target antigen is the membrane protein. Some of protein or RBC are the target antigen. You have some type of antibody against them, and it leads to hemolysis and anemia. In different disease, the type of antigen may be different. For example, in pemphigus vulgaris, it's a kind of skin disorder, bullous skin disorder. The target antigen is desmoglein, for example. Good posture, myasthenia gravis, Graves' disease, these are all of the type of disorders which are caused by type 2 hypersensitivity, and these are the target antigen. For example, in Graves' disease, TSH receptor is target antigen, antibody attached to TSH receptor. And opsonization, complement activation, and antibody-mediated cellular dysfunction will be happening. I go from examples from, we have examples in the table. You should, you only read the example from the table. Type 3 hypersensitivity reaction, known as immune complex reaction, and antibody here are mostly IgG plus, also maybe IgM plus. The antigen may be exogenous or endogenous. So here antigen may be exogenous or endogenous. In type 2, antigen were always endogenous. Okay, the tissue, because the antibody directly attached to antigen in the tissue. But here antigen may be exogenous or endogenous. And you have antigen-antibody complex. This complex deposited in the organ. So the antibody directly do not attach to antigen. They attach to antibody. The antigen may be exogenous, and they deposit in the organ. And the position of antibody in the organ makes the patient symptoms in the form of vascularitis. So you have some floating, some free antigen antibody complex. They deposit in the vessel wall here, in the endothelial cell of vessel wall. And you have evidence of vasculitis. Some enzymes are releasing from neutrophil and damage to blood vessel. Damage to blood vessel. Can you remember what type of necrosis happened in this type of hypersensitivity? Can you remember from the other chapters of Robbins pathology. Can you remember in SLE, for example, in SLE?
Systemic lupus.
Systematic lupus.
What type of necrosis?
Fibrous.
No.
Fibrinoid necrosis. When a vessel or when you have vasculitis, you have fibrinoid necrosis in the vessel wall. It was the example the example of, for example, type 3 hypersensitivity reaction. So the examples of type 3 hypersensitivity reaction is SLE, systemic lupus erythematosus,
Midorja.
post-streptococcal glomerulonephritis. Here, the antigen is the antigen in the streptococcal. It's the the exogenous antigen here. Polyarthritis nodosa, for example, it's interesting. Hepatitis B virus is the antigen, so it's the exogenous antigen. This antibody antigen complex will be deposited and in the blood vessels. These are examples. You study examples from your table. Okay, I will question from the table. I will do not question from the slides. I will table from the table. So the morphology of type 3 hypersensitivity reaction is acute vasculitis with fibrinoid necrosis of vessel wall. You can see the position in the kidney, for example, in the lupus patient. We have a form of Altus reaction. It's a local immune complex disease, and in the form of vasculitis, it's a local vasculitis. You should know only Altus reaction is a form of local vasculitis, and this is the picture from vasculitis. These are blood vessels, and you have fibrinoid necrosis in the blood vessels and presence of many inflammatory cells within blood vessels. Type 4 hypersensitivity reaction, also known as cell-mediated T cells, are activated in the type 4 hypersensitivity reaction. It's a delayed type hypersensitivity and involved reaction by T memory cells. You need first contact sensitized person, and you have a subsequent reaction. So you should know what is the example of type 4
Granulomatous,
reaction.
RA,
Well,
IBS, rheumatoid arthritis, and IBS. And something to do with vaccines.
Didn't get what you said.
The types, type 4.
Yes.
Rheumatoid arthritis,
Rheumatoid arthritis.
this one, and IBS.
Maybe, or one of the important of is tuberculic skin test. Tuberculic skin test when you want to
Vaccine.
TB. Tuberculosis. Tuberculic skin test and tuberculosis is an example of type 4 hypersensitivity reaction. We have a type of inflammation, granulomatous inflammation. It's a top-line delayed type hypersensitivity reaction. Why granuloma is very important? Because granuloma, when we see granuloma in the tissue, we have some differential diagnosis. For example, tuberculosis infection. It's a very important type of infection which makes granuloma. What we see in granuloma is accumulation of macrophages. We call them epitheliohistiocytes in the center. Okay. This is the structure of granuloma. Let me show you because you have a slide of granuloma in your practical session. You have these are macrophages in the center of granuloma. Or epithelioid cells. And you have around these macrophages, you have some lymphocytes. And around this, you have fibroblasts. It's a type of it has a kind of type 4 hypersensitivity reaction, granuloma. When we see this structure in the tissue, accumulation of epithelial histiocyte in the center, around them we have a polar of lymphocyte, and around them we have fibroblasts. We call this granuloma. And one of the main differential diagnoses when we see granuloma is tuberculosis infection. Granuloma may be necrotizing, have necrosis, or may do not have necrosis. The tuberculosis may be necrotizing granuloma. This is a picture from your root. You have epithelial cells in the center here. These are macrophages or epithelial histiocytes. You have a collar of lymphocytes, and around them you have these are pinkish cells are lymphocytes, and you have fibroblasts. And you may also have multinucleated giant cells. What is multinucleated giant cells? Multinucleated giant cells are large cells which have multiple nucleus, and they may have an arrangement of nucleus, maybe somehow horseshoe-like here. We call this granuloma. And in the tissue, if you look at under microscope, this is granuloma. These are epithelial histiocytes here. This is multinucleated giant cells, and these are lymphocytes here. Under microscope, we see something like that. These are epithelial histiocytes, lymphocytes, and multinucleated giant cells. Okay, I have only about 50 slides more. It's about basics of immune disease, but more in detail about immune disease. You have some other lessons in Sunday and Monday. In autoimmune, what is autoimmunity? It means reaction against autoantigen, self-antigen. And result of immune reaction is caused maybe due to high affinity autoantibody. The affinity of antibody to the cells more than is needed, or activation of pathogenic self-destructive T cells. These are some of autoimmune disease. Some of them may be mediated by antibodies. These diseases are mediated by overactivation of antibodies. These are, for example, autoimmune hemolytic anemia, SLE, systemic lupus erythematosus, myasthenia gravis, Graves' disease. Maybe some of these autoimmune diseases may be mediated by T cells, for example, diabetes, MS, for example, rheumatoid arthritis. And some of them may be, they postulated to be autoimmune. I do not have any work with them, but these are important. T cells and antibody mediated are important. Autoimmune disease may be organ-specific. That antibody or immune response is against a specific type of organ or maybe systemic. So we call all of these autoimmune diseases also collagen vascular disease or connective tissue disease, because connective tissue and collagen vascular organ are very susceptible and prone for showing the immune reaction. For example, many patients with autoimmune disease have arthritis, joint pain, muscle pain, myositis. They are very same, and they share the same symptoms, all of the patients with autoimmune disease. We have a process named tolerance. What is tolerance? It means unresponsiveness to self-antigen, which is the fundamental property of the immune system. and breaking down of tolerance is basis of autoimmune disease. When a lymphocyte, what happened? When a lymphocyte during activation reacts against a self-antigen, the lymphocyte should be eliminated from the body. Okay? When a lymphocyte is reacting against self-antigen, should be eliminated. Immature T cells and B cells that recognize self-antigen, you have a process of central tolerance. For example, in the central lymphoid organ, when they react against self-antigen, they will be killed by apoptosis. In the B cell lineage, some of the self-reactive lymphocytes switch to new antigen receptors that are not self-reactive, but most of them are going apoptosis. In the thymus, many self-protein antigen are processed and present to thymine antigen presenting cell. So we have a positive selection, we have a negative selection. What is negative selection? Negative selection means any immature T cell that reacts against a self-antigen undergo apoptosis. It happens in the thymus. And central tolerance is imperfect. Not all self-antigen are present in the thymus or bone marrow. And we have peripheral tolerance. What is peripheral tolerance? In peripheral tolerance, mature lymphocytes that recognize self-antigen in peripheral tissue become functionally inactive or anergic that are suppressed by regulatory T lymphocytes. So my last question is, what is the difference between central tolerance and peripheral tolerance?
Central tolerance happens in the lymph organs and the nose.
Yes,
Yeah.
and it happened in the immature T cells.
Yes, and peripheral tolerance happens for the immature lymphocytes and in the peripheral periphery of the body.
Yes.
By
And
regulatory
the
cells.
peripheral tolerance is mediated
T
by
regulator.
T regulatory lymphocytes. Yes, they suppress and make them anergic. But in the central tolerance,
They kill
all
them,
of them they will
apoptosis.
apoptosis. Yes, they are not anergic. They go apoptosis. They will be dying. Anergy means functional inactivation rather than this. Okay, the difference between anergy and apoptosis. Yes. This is for yes, this is the central tolerance, which happened in the thymus and bone marrow, and with deletion of apoptosis of the self-activating cells. And this is peripheral tolerance, which means anergy of these cells. Why the person is very susceptible for autoimmune disease? They may be genetically, may have some genes in the person which the cell influence lymphocyte tolerance, and may some environmental factors such as infection or tissue injury may also display response to alter display of response to self-antigen. Or maybe some of the genes in the HLA groups, they are very susceptible for mutations and make the patient susceptible for autoimmune disease. I will not give any question from this table. I think it's difficult, but you should know for your exams, maybe other exams. امتحان جامعتون مثلا ممکنه باشه. ولی من تو امتحانم نمیرم. Okay, any question?
Not yes. So
I will put the slide in the